So there was this unmet need. Back in 2013-ish, CMS actually approached GSA and they said, people aren't using the annual wellness visit. And surprise, 10 years later, guess what? They're still really not, right? So well. But anyway, we know that a big part of that annual wellness visit is to screen for impaired cognition and to detect impaired cognition earlier. And so GSA did what GSA does well, and that's pulled together a work group. And in that work group, they addressed what they called, there's a quote here from the white paper that the work group put out, where they said it's really a frequent but frequently overlooked gap in care for our aging population, and that is where we're really missing the boat on detecting early impaired cognition. And often the answer, particularly back then, was, why do we want to find it early anyway? What can we do anyway? And we certainly know a lot more now that there's disease-modifying treatments for a small part of that population, but there's also a lot we can do to wrap people in supports and services to keep them chugging along well in the community. Carolyn's going to tell you about the risk-based approach to that when we get to that section of the kit. But out of this white paper, this framework was born, and it's called KAER, K-A-E-R, for Kickstart the Brain Health Conversation, Assess for Cognitive Impairment, Evaluate for Dementia, and Refer for Community Services. Again, recognizing the importance of enveloping the individual and their family in supports and services. And so from that white paper came out in 2015. In 2017, the first care kit for brain health, or what we call care toolkit for primary care teams, was launched. In 2020, it was updated to become a much more online, streamlined version. And then in 2022, it actually started in 2021, developing a care toolkit for obesity in older adults. When you think about brain health or dementia and obesity, there's a lot of similarities. Nobody wants to talk about either of these topics, right? Providers are pretty ill-prepared in many cases to address either of them. And frankly, if you can assess and get to individualized care and refer for supports and services in both cases, you can do a lot better for outcomes. So we did launch a care toolkit for obesity. The half of my time that I'm not spending on brain health, I spend leading that work. I love that work. I'm very, very proud of GSA's footprint in that work. And so our care toolkit is an online format. It's a compilation of the best of tools. Most of the stuff in this is not our stuff. We're linking out to all the research-based stuff that is out there. Our work group came together, and you're going to see who our superstar work group is in a minute. And they really focused on, these are what we think are the best. We often get the question of, what should I do in my practice? And the bottom line is, you guys all know this, if you've seen one practice, you've seen one practice, right? You've got to figure out, based on resources and availability and patient load and all of the different things going on in that practice, figure out what's really best for you. There are in each section, and there's 4 main sections, 1 to go with each letter. I'm going to move this. I'm looking through that. It's going to be like above your head.
Yeah,
I think.
above it.
All right. So there are key sections for each and every, key takeaways, for each one. There's a section on ways to get paid for care-based care. And we're going to talk more about that in a moment. We include information about how to effectively communicate for older adults. You guys, if you put in a abstract at all for this conference, you would have seen a single page of information from Reframing Aging that's all about using person-first information about older adults. GSA is the national convener for the National Initiative to Reframe Aging. All of that information you can link to our website. But I was delighted when I opened up the call for proposals for GAPNA. I'm like, they're using this stuff. This is awesome. But it is all about reframing and getting rid of the silver tsunami and the doom and gloom. And instead, we're all aging and we're all getting older and we're making it a better place for all of us as we age. So there is some of that in the care kit, and we certainly refer back. And again, we have tables and exhibits. It's all linking out to the best of the best. And we do have some additional resources that branch off. Basically, everything in my world goes back to one care kit or the other. And so the KAER framework I already told you about, and really it is this idea of a supportive document of practical approaches, clinical resources, validated clinical tools, And the primary audience for this is primary care teams, with the idea that no primary care team is going to take it and put it all into place today. But the idea is that they're going to take it, choose what approaches work well, and then implement them in their practice. I do some training in collaboration with the Alzheimer's Health System folks around CARE, and I had one group who was in a federally qualified health center, and they were like, we just need our docs to start asking a question. We're not even talking about brain health, where others are far more advanced than that, and they're really ready to put in much more robust practices and things. But really, the idea is that the primary care is the principal audience, but we know that many different audiences can use this. Caseworkers in the community are someone that really gets a hold of this and enjoys this. I will tell you that in the future development, we have in the works right now, it's actually with our review panel, we have in the works a care companion for the IDDD population. We recognize that there are individuals in the ID population that reach a certain age, and they are diagnosed over the phone by someone who says, oh, they have Alzheimer's because they're a certain age. So clearly there's a great opportunity to do better, and we're really excited about that. That will launch in the end of November. And here's our awesome work group. We have Amy Bohm and Allison Lee from the Alzheimer's Association, Dr. Clevenger and her colleague, Laura Metters. Laura is my social worker friend. I have to say, I love her. She's the most amazing lady, one of them that I've ever met, I think. She and I recently did a podcast with one of their patients, one of their patients' wives, to tell the story of someone's trajectory with Alzheimer's. It was amazingly powerful. I was the crying, blubbering idiot by the time I was done talking to them. We have Diane Ty from the Milken Institute, Bonnie Bermans from the Ohio Council for Cognitive Health. If you have not checked out their resources, they are incredible. They're doing amazing collaborative stuff in Ohio. We have Josh Chodosh and Sue Borson, who lead the Bold Center on early detection. And then we have Fred Ketchum, who is out at the University of Wisconsin, who's a neurologist and a terrific guy. And so we do have a section, as I mentioned, on getting paid for care. Now, we did a pre-conference last year before the GSA annual scientific meeting. Carolyn talked about how to get paid for care-based care, and I will tell you there was a gasp in the room. They are not getting it right like she is getting it right out there. So Carolyn's going to take it away and tell you some of her practice pearls.
All right, then. Yeah, that sounds better. Okay. So we did talk about how to get paid. We're going to start talking through so one of the reasons we get really scrappy about getting paid is because Integrated Memory Care, or IMC, is a nurse-led practice. It's a startup. We're able to incubate in a large health system at Emory Healthcare, which is wonderful, but we got to make sure we're doing good care and that we're getting paid for the care we do. And I will give a shout out to the American Nurses Foundation, who funded us to do this focus on direct reimbursement for nurses, and we mean all the nurses in the practice, not just the nurse practitioners. So because we've been doing that now, we've been open 8 years, we figured out we were pretty scrappy about making sure we're paying attention to our billing codes and staying on top of things. So I'm going to start with this sort of first idea that just to remind all of us, this was something I learned. I used to share this one with a lot of our students, this DX before TX. This was a license plate somebody had. The idea is that, how are you prescribing or implementing a treatment plan if you haven't really done a good job understanding what we're treating? So that's where we're going to start and then also end this process with the best diagnosis that you can. So there's a big focus, of course, on timely and accurate diagnosis at this point. I think this is GAPNA. I hope I'm preaching to the choir, but other people have these questions for us, right? Which is, why are we pursuing this? There's, quote, nothing we can do. Last time I checked, there are not cures for a lot of things, but we still tell people what's wrong with them.